Hello, everyone. My name is Olivia Lee, and I am a cornea fellow at Moorfields Eye Hospital in London. And I would like to share with you today some work that we've been doing, personalizing predictions from when a keratoconus patient first presents to us in the clinic. And I'd like to acknowledge my co-authors as listed there. The prevalence of keratoconus has been found to be much higher than previously thought. And also with improved diagnostic techniques, there's been an increase in the number of patients being cross-linked and also being subsequently followed up in the outpatient clinic. As you can see here in the light blue, this is our local data from our early keratoconus clinic at Moorfields. Over the last 10 years, there has been a steady increase in the number of patients requiring collagen cross-linking. And similarly, you can see that there's an increase, a continuing rise in the number of patients attending outpatient follow-up appointments, and we routinely follow up our patients for about 5 years after their initial treatment. There is a slight drop-off in 2020 during the pandemic, but we are again catching up. There are challenges to providing personalized patient care. So should we be blanket providing cross-linking to every patient who attends the clinic with early keratoconus, or should we be monitoring? So which patient should we be monitoring for progression, and who should undergo cross-linking early at presentation without waiting for evidence of progression? And which patients can we safely discharge without considering cross-linking treatment? To answer those questions, we performed a retrospective cohort study of over 9,000 eyes from over 5,000 patients with suspected or confirmed keratoconus. 3,500 of those eyes received cross-linking, and we were also able to include genetic data from over 900 patients. And what we looked at was when the patients first presented to us and analyzed the time it took them to either demonstrate progression or progress to having cross-linking treatment. We defined progression for treatment according to this table below, dividing patients up into either early or moderate or advanced keratoconus. And this has already been published in an earlier paper from our group in the AJO this year. Our results showed that 33% of the variation in time to event came from 4 significant covariates, and these were age, Kmax, front K1, and minimum corneal thickness. What was interesting to us was that ethnicity was notably absent from this model. Additionally, the 28 single nucleotide polymorphisms that were identified previously in a GWAS study that increased the risk of keratoconus were not found to be significant in predicting the progression to needing cross-linking. We used these results to generate a predictive calculator. And using the 4 significant covariates, we are able to offer a prediction as to when a patient is likely to progress or need cross-linking treatment. So here is an example of where a patient's data had been entered. So the age of presentation, the Kmax, front K1, and pachymetry. When these data have been entered, we're able to provide a graphical representation of how likely a patient is and when they are likely to need cross-linking And so as you can see here, the graph shows this is at time of presentation, and this is up to 5 years. And on the y-axis, we have probability of having cross-linking, and the patient in red has a high ability of having cross-linking in the first 2 years. And so in a patient who is likely to require cross-linking at some point in the first few years, it makes sense to intervene early and treat them at presentation. In a patient who's less likely to require cross-linking over 5 years, it may make sense to monitor them initially to demonstrate progression before initiating treatment. I wanted to share a clinical scenario with you, a patient that I saw in clinic, which I used the calculator to help me. So this is a 19-year-old man who was diagnosed with keratoconus. The right eye was more advanced than the left eye, which is something that we frequently see with asymmetric disease. And because he only felt that the vision in the right eye was significantly worse, he didn't want any treatment done in his left eye, which he felt was his good eye. We therefore entered his data into our calculator with his age at 19 and took the parameters for both the right and left eyes to create the predictions. And this was the prediction from our calculator. So the right eye, which we know is more advanced, had a very high chance of needing cross-linking within the first 2 years. And this was consistent with what we felt clinically. With the left eye, where the patient was less convinced, he saw that there was a very high chance of him needing cross-linking at some point within the first 5 years of diagnosis. And understanding that keratoconus is a progressive disease that can't be reversed, he elected to undergo bilateral cross-linking. And in order to provide a user interface that was helpful to both patients and clinicians, we did the reverse, the probability of not having cross-linking. And as you can see, the probability of his better eye, his left eye, of not having cross-linking is, again, less than about 20%. So this was one demonstration where this model was useful clinically in helping the patient to understand his own risks. And we feel that this calculator would also be useful for clinicians in terms of helping them to prioritize which patients should be seen and treated first. And also individual units can use the calculator to set their own treatment criteria, which will help facilitate delegation of the triaging process to clinicians who are less experienced in the management of keratoconus, or even non-clinical staff from a managerial point of view in terms of managing patient numbers. We also feel that this calculator may contribute to improved outcomes, such as allowing high-risk patients to be treated earlier, with clinicians being confident that they're doing the right thing without waiting to demonstrate progression. And we may also be able to prevent or reduce overtreatment with more careful monitoring of lower risk patients. And so we would welcome you to try out our calculator, which is still just in the study stages, and but the work has been submitted for peer review, and I will be happy to take any questions. Thank you very much.